We are recording. Okay. So just a few housekeeping items before we jump into sharing experiences and whatnot. So as you'll remember, the recording, we had a lot of technical difficulties with the recording from the first webinar. Something happened with WebEx and they lost our recording. It took them quite some time to get it back, but we do now finally have a copy. The issue is that the copy of the recording, we have the actual file, and it's much large to send over email to you. So what we're going to do is Christina and I are going to sit down this afternoon and re-record it from the file into WebEx so that we can send you a link, and it will be much easier. And if something happens, we still have a copy of the recording. So it'll be okay. We're going to get that out to you within the next couple of days, and actually I'll probably put the recording link for that one, the email that comes out with the recording link from the webinar we're having right now. Second update, there are some updates to the tool, so we'll share that out with you as well. Based on facts that have come back in, we've added in SNOMED codes in case some of the doctors are coding using those. And you can search that way. And then we're also taking a look through all the feedback that we've received from you today and combing through that, making sure we've got all the updates and everything into the tool. And if there's anything else, we'll share that out with you. So keep the feedback coming because there's still, there's still a lot of areas that haven't gotten rolling with it. And I know there's, a lot of places where divisions are just getting started with engagement with their members around patient medical homes. So we'll keep rolling with the compensation as the current PDSA with still the 5 per division, and we'll see how that goes going forward. So the last piece related to that is around training and easier ways to get to that data in an EMR. So, as I mentioned, I think on our last webinar on the tool, we're exploring options with some of the vendors around some canned reports. TELUS is, of course, wanting to use dashboards that put together, which are pretty cool. So we are working through these and have received proposals from a couple of the vendors. We're also thinking through more around the training and how we can better support you guys when you're out there and make sure you have the information that you need to be able to use the tools to find it, find the data in the EMR. Okay, so we talked about those. We talked about how it's going to run. So last thing, the next webinar is going to be on the EMR functionality tool. So that's the next one coming up. I think that one will be definitely easier than this one to use. It's more of a subjective questionnaire and is really looking at where the physician is in the spectrum of the disease level. A big piece of which is that we recognize that since PETO finished and PSPTG over a year ago, a lot of those doctors who were functioning up around MU3 have put back into old habits and aren't doing that anymore. So it'll give us a good idea of where they're at, and then we can, we're thinking as well about the different spectrum of support that's needed for those doctors. So not you guys to dive deep into the EMR and support those doctors who are functioning under MU3. We're thinking about different strategies for that group to get them back up again and sustaining their EMR usage. So with that, we've got about 20 minutes until Bruce is going to join us. So I think I'm just going to open up the floor to those of you who have used the tool. And there were some of you who I reached out to yesterday, so I'm hoping you will jump in with your experiences.
So it's Ruth Ann here. I'll jump in right away, Aaliyah, since I do have another meeting coming up at 9:15. So I just wanted to share, I have used the tool with 2 clinics, both on Wolf systems. So that was an advantage for me because the 2 MOAs I partnered with were fairly comfortable maneuvering through their EMR system. Because I was rather overwhelmed with the guide that we got from Wolf to start. So I found it easier to do it with them and then link back to the guide for the things we weren't clear on. So that was one of my strategies. I found one clinic, they were really eager and anxious to get going, so they did all their panel cleanup in about 4 days. Worked through all the things, the MOA spent close to 8 hours doing that work over the course, as I said, a weekend and about 3 or 4 days. So that was good to see. The only questions we had were that last section where we look at the patient self-management and I can't recall the other one. But since we haven't had any clear direction yet on what are the types of questions or how would physicians actually capture that, what are the recommended questions to ask to see if they're doing that. One of the suggestions my physician had was, especially around self-care management, look at those complex care patients that you're already looking at. Those patients should have both most documents in place for their advanced care planning, but there should also be maybe some end of life or some self-management goals in there as well. So those were kind of some of my experiences. My other group's a little bit slower. They're finding it, you know, they have other work to do, and each group I find uses their EMR a little differently, and that was probably one of the key things for me is helping them do what we're asking, identifying panels, identifying registries, but in a way that makes sense to them and the way they use their EMR, because not everybody uses their EMR the same way. So
that's great, Ruth Ann. Thank you so much. And I think, too, because we haven't really talked about those last few indicators and we're covering that today, I know it's hard to look at that and really know what exactly you're looking for, how to look for it in the EMR and everything. I also think it was a really great idea for you to start it with a couple of clinics where the MOAs were really strong in the EMR, because I feel like that's a great opportunity for you guys to learn together about how to look for the data and how to use the tool and all that stuff. That's really awesome. So thank you so much for sharing.
Okay.
This is Nancy in Prince Rupert.
Hi, Nancy.
Hi. I started the tool with one of the larger clinics here. We have MedAccess, and I have MOAs that don't have very much experience on well, I shouldn't say they don't have very much experience. They use the EMR every day, but for looking for things and running reports, and looking at dashboards, they don't have very much experience that way. So it's, and I as well don't have that much experience on MedAccess. So it was a little bit of a super learning experience for all of us. And it's taken quite a long time. The physician has been open to having conversations and participating, hasn't spent a lot of time on it, but the MOA has definitely spent quite a few hours working on the cleanup and trying to understand and trying to just figure out MedAccess. So it's been a huge learning curve for them, for me, and for the physician as well.
Great. Thanks so much, Nancy, for sharing. And I know you and Bruce, I think, have been chatting a little bit about pieces of the tool and sort of how to move those stuff too, right? So
we have been, and that's been super helpful.
Yeah. Can I ask, so, and I apologize, I know that Rupert is fairly small, but I don't know if we would really classify it as sort of like a rural area or not, and One of the things that we're thinking about, too, is the applicability of the tools in more rural areas, and so particularly for those of you in the north and in the interior, if you've had a chance to, when you've had a chance to use the tools, does it make sense in the practices, the way the practices are set up, and that sort of thing?
Did you want to comment? Or should I comment on that?
Sure. If you have a comment, that'd be great.
We've got about between 10 and 12,000 people here, so it's quite a big community.
Okay.
And I think that I think it's really supportive of the physicians because I think what's happened here in Prince Rupert is they've had MedAccess and they're using MedAccess, but they don't really use it. It's just basically a glorified paper chart. So I think this process and going through these tools will be it has been really, really supportive for the physicians. They've really jumped on learning sessions, so the lunch and learns. They've just really jumped on that, and they're so appreciative and just really want to learn more about it. So I think it's been really good overall for the community.
That's great. The lunch and learns, Nancy, that you mentioned, those are the ones that Jody is doing with you guys as well, right?
That's correct, yeah.
Yeah, okay, that's great. So for the rest of the team, in the north, Jody Johansson is one of the previous pedo PACs, I think. Sorry, Jody, if that was wrong. But she's been doing sort of lunch and learn webinars with the coaches and the GPs, and I think sometimes the MOAs as well, sitting down together on the EMR, because she has quite a lot of experience with a few of the EMRs. So it's something that's working out well up there.
Absolutely, it's amazing.
Great, thank you.
So, Aliyah, this is Shafali, and I would share my experience as well, since we're talking about MedAccess.
Great.
I actually reached out to some of the physicians in our division and just sort of introduced that based on the information that had gone out by GPSC to them about how we're moving forward, that this is an opportunity. And so one of our super user physicians actually approached me right away and was interested. So this clinic that I worked with then, just to kind of mention, they really are really good users of MedAccess EMR. So when I went in, one of the things that I did was initially meet with the MOA and started off with just even giving her the why of why we're doing this, just as we talked about on the calls. And I think that was really, really helpful to her, and I think that would be something I would recommend for everybody, because sometimes the MOAs don't have that real reason, and once they understand the purpose of this, it really actually helps to move the conversation along nicely. I, too, just as Ruthann mentioned, had brought my cheat sheet with me for MedAccess, as I'm not a big user. I don't know the system as well either. And so I didn't actually really need to refer to it too much. As we went through looking at the different indicators, she was really terrific in helping guide that process and getting us to the scores that we needed to. And one of the cool things that came out of the MedAccess, one of the indicators around where it talks about looking at finding out what patient age groups panel holds, well, she was able to produce a histogram and print it for us, and it was really, really interesting to see because it actually graphed all of the different, what their panel looked like. So they have a really young panel, and so you saw this graph with mostly patients that are actually in the younger age group, and so it was just really a good visual. That was cool. Some things that were revealed throughout the process was that they were using some ICD-9 codes that were not the ones that we were asking them to look at. And so that actually, made them realize that maybe they were using actually incorrect codes for some of the things. And so that was huge. And So they're going to change that moving forward as part of their action plan. So for example, for the conditions ischemic coronary disease and ischemic cerebrovascular disease, they were using the same code instead of two different ones. And Bruce pointed this out, and I followed up with them. So that came out. Even for depression, they were using ICD-9 296 instead of 311, so things like that showed up. The other thing we recognized is that when we calculated percentages, some of the percentages were quite different from what the reference data showed for particular chronic diseases. And so when we actually went back to look at the references, some of that information was collected for a population of age 20 plus, but some of it was for populations of 35 plus or 40 plus. But when we actually, so that had to be integrated in the calculation, because then we had to actually look at their overall patient panel and subtract all of the age groups that were 40 and under, and then kind of calculate from the 40 plus. I don't know if that makes a lot of sense to all of you, but we put in a calculation to have more accurate data. And so that was really interesting. Other things that showed up were things like the chronic pain. When they actually, the chronic pain code is 338.4, but actually drops the decimal. So if you try to look for chronic pain patients utilizing pill, some discrepancies that came up. So I actually brought that forward as well to Bruce, and I've sent that over to you guys. Anyhow, it was really a terrific experience. It took about 1.5 hours between myself and the MOA to go through to the indicators that we've sort of been given information about up till now. And then I spent about an hour and a bit with the physician, and now they're actually working on the next steps, their action plan of going back and looking at their ICD code usage versus what the recommendations are, that kind of thing. And we're going to meet once we have more information about the next few indicators and then kind of finish things off. I will stop there.
Cecilia, that's awesome. That's great to hear that, all of you so far have had really good experiences, like some challenges definitely, but good experiences overall. I think the age histogram too is a really neat thing because I think it definitely helps when you're looking at the indicators and the prevalence because of what you said, like certain indicators, like the reference ranges are for different age groups, and if you have a practice that's a very, very young practice, very young patients, then you're not going to see the prevalence of heart disease or diabetes or COPD as you would see in a practice that really reflected sort of the same age range as the general population. So that's something that's really great to note as well.
Aaliyah, it's Ruth Ann, and I just wanted to say in Wolf, we don't have that capability to pull up a histogram. So what both my MOAs did was just gave me the age breakdown, and I created a histogram on their tracking sheet for them as a fourth page, and then just created the graph. And it's having that visual is really important.
That's great, Ruth Ann. That's really cool. All right. Thanks, guys.
Hi there, it's Tamara. I was just wondering if anyone had any experiences with IntraHealth at all in the province.
Hi, it's Denisa here. I use IntraHealth for one of the clinics that I'm supporting. Actually, I have a challenge that Aaliyah asked me to share. One of them is just just trying to follow through the patient cleanup, the tool that Bruce had created for us. As part of the neighborhood network, I've been helping the GPs with, clean up their panels and just refine their registries as well. One of the things I noticed just going into the clinics was their ICD-9 codes were not on the problem summary, so the patients weren't really identified correctly.
Yeah.
So if you were to pull a registry, I'm not too sure where they were pulling it from, but I think they had like a handwritten list of the the patient's names. And so when you're trying to pull it from the problem summary, nothing was coming up. So part of the neighborhood network there was a focus around the chronic disease management, and I had helped them kind of transfer the ICD-9 code from the problem summary from the billing summary to the problem summary. And now they have proper registries where you can pull it out through the problem. But now as I'm going through the panel worksheet, I'm trying to pull things such as dementia, anxiety, depression, and my numbers are quite low, and I think part of it is some of the GPs may not even be identifying the patients correctly onto the problem summary right now.
Are you using are you using stored queries to do that?
No, I'm doing it through groups.
Okay, okay.
Yeah. It shows a list of patients.
Yeah, I noticed when I did searches through groups, I wasn't able to use starts with, and I've noticed with my physicians that sometimes they'll use like for diabetes they'll use 250.1.2. So if you use stored queries, you can actually use a field called starts with, and then you'll pull more data that way.
Yeah. I did try it with stored queries in that clinic, but I didn't. There's not a variation of numbers. A lot of the GPs there just use 250. Like there's no decimal numbers at it.
Okay.
Hi, this is Jennifer Congo. I also use Profile. Can I just mention something that Denise had also mentioned, and that is like going through and finding that some of the physicians are not having the correct panel, because I think not only are they not coding it properly in problem summary, they're also not coding the ICD-9 codes properly. So depending on how you pull up the stored query, it depends on how you would identify it. So it's right. It means that if you have a range from like 250.1 to 250.9, you would have to identify that in the stored query itself. So you need to configure the query in order to make sure it accounts for the whole range. That's all I want to say. Thank you.
Have you built some of those queries at all?
Yes, definitely. Yeah, I built the query. I also sent my cheat sheets to Aaliyah, and I believe Bruce had a look at it as well, even though it is for InterHealth profile. There's a cheat sheet that I do have. I've been sharing it with all the team, so hopefully it gets to you as well. So, yeah, so we'll see what everyone's feedback is on it. But in means of the stored query, you just kind of have to identify exactly what you're looking for. And, yeah, so thank you.
Aaliyah, can I just are we working with clinics right now that are already on Profile, or I thought we were holding off until they're back in on things?
The ones on Profile we were sort of holding on that because they're more complicated. The reporting, like being able to actually pull the data out of the EMR is really challenging, as Denise and Tamara have just talked about. So it's one of the first ones we actually reached out to around looking at turning, do they have the ODD available? Could we get the data that way? Like, what other ways can we go? So if you do have more experience with InterHealth and you have a clinic where the MOA and the GP are really strong, then it's certainly something that you could go ahead with, I think. But if it's something where it sounds like they're operating, basically using their EMR as a glorified scheduling system, and if you're not feeling really confident in your abilities with InterHealth or Profile, then it's something that I would try to avoid for now.
Aaliyah, it's Erin. Almost all my clinics except one are on IntraHealth, and I'm meeting with the ED today. So do you have a rough ETA when you might be at a more usable place?
So we do have a proposal from IntraHealth around some canned reports for that Kelsey Gallant has basically on her desk that she's following up with them. It sounds like if we go ahead with that, we can have that by the end, I think the end of October, but I'm not 100% sure. And Kelsey, are you on the line?
I am, that's correct. Yeah, we're targeting for the end of October, and that would include training for all of yourselves as well as any of the key peer mentors that you feel will be part of sort of doing this work in the community. So we'll be setting those days up probably for early November.
Wonderful. Thank you very much.
It's Candace here. I have quite a few clinics on IntraHealth, and what you might find helpful is if you can get a hold of the ODD guide, the dashboard guide, from when the folks were doing a lot of dashboard work at PEDO, because it has a lot of screenshots and tips and tricks on how to increase the accuracy of your data in all of the demographics and coding, billing, problem summary structures, medication structures, all that kind of thing, allergies, do not resuscitate. So if you don't work with a PEDO person who may have that, we could share the dashboard guidelines that were made. There's lots of good tips and tricks in it.
That would be wonderful if you could share it. Thank you.
Sure.
I wondered if it would be out of line to say this, but I've built some stored queries that fit this tool, and I don't mind sharing them, but I think that's the work that IntraHealth is supposed to do.
Yeah, I think if you're moving forward and we have things that are correct and are working, then we definitely want to share those. So if you want to send them my way, I can send them out with the information after this call.
Okay. Okay.
All right. And I think, Bruce, are you there? Oh, no, I don't think he's not called in yet. I see his name on the list, on the webinar list, but I guess he's not in yet. Does anybody else have anything that they wanted to share on their challenges or what they've been doing and what's been working?
Ali, it's Adam. I just have one question for where the stored queries will be kept or sent out. That process, is there any chance we can use like the RST set or something and then organize by EMR so we can be like, okay, we know where to look and find these things? And then if we're uploading things like maybe that PEDO book or any sort of materials, it could live there, or is that too crazy?
Sorry, Adam, do you mean like on the RST site? I think it was on DivIT, right?
I was thinking more aligned just where the same place we get our sessional forms.
Oh, like
that is DivIT.
Oh, it is DivIT.
Yeah.
And where the webinars are from the EMR, the original.
Okay. We can look at storing everything in there. I'm not sure how stable that platform is right now. I think they're actually exploring options to replace it. So the other thing is that high up on my list of things that we want and need is some sort of repository library somewhere where we can have all of our documents and all of our support materials and all of that stuff in one place. Like a forum, and Christina and I were talking about this yesterday, and there's a lot of things in it that I want, and it's been on the list for a while. So, who's working on it? Oh, so we have somebody working on it. So we're hoping to get a little further along the line with something like that, so that we'll have something central and stable and easy to access, and that will hold all of our.
In the meantime, we'll look at the possibility to get them on the DivIT.
Yeah. Do you mind, can you look at that later today, Christina? Thank you. That's a great point, Adam. Thanks for bringing that up.
Cheers.
And I think I see a phone beside Bruce's name. Bruce, are you there?
I'm here. Hello, everybody.
Good morning. All right.
Sorry I'm late.
Oh, no, No, not free. So why don't I turn it over to you and we can talk through those last couple indicators around the panel management piece. And then if we have time, we'll have some more time for sort of questions about that or comments or other discussion.
Okay. So I had put a couple of indicators on the panel management more as placeholders rather than to say those were the specific indicators that were necessary to be done. I'm hearing feedback from people, not just RSTs, but also from divisions, that they have concerns about the direction that we're going in doing panel cleanup, that they don't feel that that's relevant to their physicians. They want to be getting into things that are clinical and practical and meaningful and relevant to them. And I certainly heard the same about, they're doing projects on patient medical home, and they want to be able to look at the EMRs and get measures and indicators on that topic from their EMRs. And, I think a classic example was one that Denisa had sent in, and thank you, Denisa, that she'd been in to see one of the doctors and had a prevalence of, I believe it was hypertension, almost bang on what you would expect it to be, and then all the other prevalence numbers were zero. And, so the comment from Denisa was, whoa, we looked at billing, we looked at other things, and still we're having a hard time picking up, where the rest of these patients were that should be there for things like heart failure, COPD. So my caution before saying anything about diving into what panel management is and relevant, panel management is now starting to look at those measures that are more clinically relevant to the physician, and some people are there. But I would guess that the majority of people are still at that panel cleanup stage, and we're still looking to figure out how they can actually identify their patients for panel management, for patient medical home. If they don't even know, and if they do a search and can't even identify all their patients that have heart failure or COPD or diabetes, other than by, sitting down and randomly thinking, oh, gee, I think Joe Smith or whoever else has this condition, then we're, really got a lot of work to do. And so my only reason for saying that as a prelude to panel management is just to say, I think the key thing is to be able to go back, and I'm going to keep re-saying this every time, why are we doing this? We're not doing this because of the patient medical home. We are doing this because it's the right thing to do. We're doing this because we all agree that providing better patient care by knowing who your patients are is the right thing to do, and that there are some unsexy, hard work, difficult steps to do before we can get to that. So I think key is when we start looking at panel management is to start thinking about, when you see examples out there of people that are doing some effective panel management who have identified a registry of patients, whatever that registry is, pain, COPD, chronic disease, ingrown toenails, it doesn't matter. But when you see people that are managing a panel of patients well and using tools to help them manage for recalls, for setting goals for patients, individualized goals, integrating MOAs into the work or other team members. It's a great opportunity to capture that story. And, you know, when we're going to physicians and being able to give them the why about how we're doing that, and they're getting sort of blown away when they look at the prevalence of COPD or heart failure of 0, and that they've never recorded anything to do with smoking in the right way, rather than just saying, well, got lots of work to do, get your nose to the grindstone, get to it, bring those stories out. And I think to that point that I just caught on there about having that provincial repository of tools, we need a provincial repository of stories, of successes with panel management, with successes and stories of how people got to where they got to, and what kind of work that they did, and then how that it benefited them, especially as in regards to the key things that physicians are interested in is time, better time management, saving some time, having them feel like they've got some autonomy in what they're doing. They're not being told they have to do something. They have to want to do it, and they have some control over some of the direction that they're doing. And that they can get good at it. You know, they can actually get a mastery on all this and be able to do it well. And then that final piece, as I mentioned before, was, you know, it's for the greater good, improving patient care. So back to panel management, my apologies, is the key thing with anything on any of the panel management items that we're working on, and alluding back to what I've said, is being able to have the proper registry, the proper identification of all those patients as the denominator for whatever panel management item you're going to be trying to tackle. So an example that I've used many times is that in my office many years ago, I happened to have a patient come in who hadn't had the tetanus shot for a while and had been into the emergency room to get a cut, and when they left, the ER doc had asked them, and they said they didn't know, and for whatever reason, didn't do the tetanus shot. So I thought to myself, geez, you know, I wonder how many of my patients don't I know what their tetanus status is. So I went and took a look in the EMR, because I record tetanus shots and things like that, and found out I only knew about 4 or 5% of what the status was of their tetanus shots, whether they're up to date in the last 10 years or not. And so I said, well, you know, I got to do something about this, because tetanus, the why the tetanus is because it's important, and we don't want people to get any kind of cut and infection that causes problems. So I'm going to track that. And if I start tracking that, if I find out that people don't have their tetanus shot, what am I going to do about it? So I talked to my MOA, and we got a whole bunch of tetanus toxoid in and the proper little needles, stocked the fridge up, had a little process going, and I made a little place in my EMR to remind me to ask the question and an easy way to record it when I gave a shot, and started doing shots for tetanus as they're going and driving public health crazy because I was ordering all this tetanus toxoid. But by the end of about a year and a half, it was up to about 86% that I had now knew the status and knew what was going on. But I only knew those numbers, 3 or 4% to 86%, because I had a panel. And that panel was all my patients that were over the age of 25. And you may ask why 25? Because people get their tetanus shots at school. Last one is about 15, so I'm assuming everybody got them at school, even if they don't remember. So 10 years later, everybody from 25 on. But that was my panel. And I had to know that panel in order to be able to use the numerator, which was people that had actually received a tetanus shot, and be able to do something with that. Now, the next sort of interesting, so that's an example of panel management, because I knew my panel and I had a question and I had a reason, a why, and then I figured out a how and a what. And that's the key part with any panel management piece that you're going to be tackling. Instead of looking at a panel and saying, you know, we're going to look at every single condition and every single patient that's going on there. Find out what the physician is interested in looking at. how does it relate, if possible, to patient medical home, in that, we're looking at patients with chronic conditions, frail elderly, mental health and addictions, those types of patients, if possible. But if it's not possible and the physician really wants to look at tetanus shots, well, that in its own way can be part of patient medical home, because that could involve team care, the MOA doing something, a nurse doing something with shots or whatever else, and could be beneficial. So there's always a way to look at it with a lens of that patient medical home to make the panel management fit with what the physician wants to do. And the second piece to that, so, the ideal thing is we want to do what the physician wants, and trying to tie it into patient medical home, needing to know your panel, and having the right question to ask, and having, as a baseline, knowing the panel that you're dealing with for the denominator for that question. That's the key part in there. And so, other things in panel management could be whatever it is that seems to be that first step that people can take to be able to move ahead. So I'm just going to pause there to sort of say, does that make sense as far as my explanation of why panel management is important, panel cleanup is important to get the denominator to be able to now start doing panel management. And panel management is always being able to use that denominator to know the group of patients you're working with. And then the numerator is being able to decide what question you want to address, what problem, how you're going to go about it, and what exactly you're going to do, and then follow it over time. I'll add something else, but I'll stop and pause and see if there's any questions or comments at that point.
This is Margie. I really like that, Bruce. I see that in physicians' office, one of the things that this will interest them, and it'll be a really good in on why this could be useful to their practice. And one of the queries or the numerator for them a lot of times is, who are my people that go to the ER a lot? So we're not sure how to run that query. So would it be an ICD-9 code, or how would you run that query?
I think you have to step back, Marjorie, and take a look at how would you be able to discover that numerator, exactly as your question. Now, the next question behind that is, how is that emergency room visit actually being recorded? And I think what you'll find in a lot of the offices you go into, if you think of what an emergency room visit is, it's an encounter. It's a visit. It just doesn't happen to be a visit with the physician who is in control of the EMR where the patient's home is. So it's a visit that ends up having the report of that visit generated on a piece of paper, which is then faxed or sent to the doctor, and they receive this piece of paper. Right. Most of the offices that I'm dealing with will take that piece of paper and say, oh, it's a scanned piece of paper. I'm just going to put it in the scanning repository, and we'll file it as a consult, or we'll file it in just the general scan box, or maybe we'll file it under something else. The ideal thing is it's an encounter, it's a visit, no different than a visit in the office, just done by a different person. And if you're thinking of it that way, it's not a consult, it's not something you requested that the patient go to. It should be recorded in the visit and documented in some way so that it's tagged as an emergency room visit rather than as an office visit. So that can be done. And then it's, as long as it's got the right tag. So different EMRs can do that in different ways. And the key is then you then search for that tag. So unfortunately, we're still working with the electronic document distribution, that we don't have a standardized way that all the EMRs will receive this electronically, and it'll already be flagged with a proper identifying features that say it's an emergency room visit. But if you're working with a physician, talk to them about what makes sense to them in their office. Suggest respectfully that it is an encounter and a visit in some way, and that if it could be recorded as such, but with some kind of a flag that they can identify, bonus. Does that help?
Oh, that's perfect. Thank you.
Other questions? Comments?
It's Candace. I just wanted to share something that changed the way I am looking at data cleanup this past week. I'm working with a physician who's done a huge amount of work. We're doing a project for CDM and complex care, and it has a lot to do with coding and demographics and data cleanup. And I met with her recently after leaving her homework of going through her patient panel to look for inactive, deceased, transferred patients and really look at the status. And what they decided to do between the physician and the MOA was phone everybody who hadn't been in over 5 years and ask them if they still consider themselves to be a patient of that physician, and if not, they would change the status, and if so, is there a reason that they needed to be called in? If so, call them in. And a bunch of names stood out on the list of patients who hadn't been in quite a while. One in particular who maybe had a little niggling concern came in, and it turns out it was a huge concern, and had surgery, and things are fine now. But for me, it's not just about going in and kind of en masse inactivating people who haven't been in a long time, but maybe consider showing the list to the physician and just looking through the names, and is there anybody you'd like to call or check in with before we go ahead and change the status? Because that was an eye-opener for me. It wasn't just about changing status, but how come these people aren't coming in and, you know, really touching base with them? So it was really cool.
If we can capture that story with just a touch more detail, like, you know, what was the condition that they caught, that's the kind of powerful story that when you go in and are saying, check that list before you batch change the feature on it, you know, from active to inactive, or from let's add diabetes to the problem list or not. That story that you just told is exactly the kind of story that I was talking about that we need to capture and share, that everybody can say and have in their pockets to be able to go into an office, and when that question comes up or that point comes up and someone says, you know, it's no big deal, we'll just inactivate them. Great story. Love it. Great. Kudos to that doctor and for you to start that work off, but kudos to that doctor and their staff for doing that. That's awesome.
Thank you.
So not hearing any questions just as a pause there. One other thing just to think about, and this is an interesting thing that we talked about at the Health Data Coalition the other day at a clinical data governance meeting, is that when we're thinking of numerators and denominators and looking at trends over time, the question came up with, do you want to look at this in a positive light so that the change over time is going to be an upward slope if you're improving, or do you want to look at it in the reverse, that the change over time is a declining graph? And it's really interesting to think about, you know, how somebody might like to look at something. And if you're sort of scratching your heads wondering, what are you talking about? A perfect example would be COPD. One of the key things is that everybody knows with COPD is whether or not the person is smoking. So do we want to identify all those patients who have COPD, so there's our denominator, our registry patients, who are currently smokers, there's our numerator. Got to record that who are the smokers are and whether or not it's currently smoking. So then you get a number, a percentage, and you look at it and you say, wow, we want to work with people that are smokers and have COPD and try to get them to, through self-motivation, behavioral interventions, whatever, to stop smoking. What's that graph going to look like? It's going to be a downwards trend. Does that make sense to the physician? Is that reasonable? Are you going to be happy with that? Or might they be interested in looking at a graph that's an upward trend? All the patients with COPD who are currently non-smokers. Those aren't the ones we want to stop smoking. We want to work with their inverse. But the graph of that is going to look like starting off 60% of my patients are non-smokers, and by the end, 80% of my patients are non-smokers. It's an upward trend graph. It looks nice, but does it make sense to the physician? And there's other things like my tetanus shot example where there was an upward trend graph because I was immunizing more people. So, I think it's a subtle point, but when you're looking at panel management, find out whether people want to look at that in one light or another, and it may be because they want to action a certain population of people and target them for doing some work, or conversely, they may want to target and action the inverse, those people that aren't showing up on the graph that will affect its slope. Same data, same denominator, but just being looked at in a different way. So that's just a thought around panel management that's sort of an intriguing sort of tweak on what you can do and how you can do it. So I'll pause there again, just recognizing that it's about 5 minutes to go to Aaliyah. So Aaliyah. So I'll turn it over to you, and if there's any other questions, happy to answer them. And as usual, if there's any email comments or anything, happy to get a hold of me.
Great, thanks so much, Bruce. All right, so 4 minutes left. Does anybody have any questions or anything else that they'd like to share before we're done for today?
Hey there, it's Ron calling from Fraser.
Hi, Ron.
I'm just wondering if there's any updates on the Oscar tool or if I maybe missed that part of the chat.
Kelsey? Are you still there?
I am. Sorry, I'm unmuting. There's no update. We're still in discussion with them. Without getting into too much detail, there's a lot of kind of, I think, projects and initiatives and things going on right now provincially too. So just bearing in mind that the vendors are have a lot on their plate. So we're just kind of trying to nail down the timing and also looking at the various options. I don't know how familiar all of you are with the HDC. Bruce is very involved with them, but some of the vendors are actually looking at trying to have, most of these kinds of reporting capabilities facilitated through the HDC. So we're still trying to figure out what's the best way and how do we still, get something to you guys in the interim. So unfortunately, I don't have any concrete dates on that right now.
Okay, thanks, Kelsey.
Aaliyah?
Yeah.
Can you guys hear me? This is Ryan from Fraser. How's it going?
Good, Ryan. How are you?
Good. This is related, perhaps unrelated. I still have in my calendar October 5th PSP training all day. And I'm wondering if you guys could update us on that. Is that what's going on there?
I don't have October 5th PSP training all day.
Okay. There were a series of dates. There were a series of dates that came out a while ago, and I still have I've saved the date. So I guess that's not.
Oh. No, did that come from me or Christina?
It might be the Child Youth Mental Health Learning Session, because that's on the 5th.
Yeah, that's the 5th.
No, I've got it as well.
Yeah. It came out from it was in just an email of save the dates from about a month ago.
I think it was Train the Trainer for QI 101, maybe?
Yep.
Oh. Okay, let me follow up, but I don't think that is a thing.
Sorry, does it say who it was from? Yes.
Yeah, I'm not sure at this point. I was looking at my calendar, and I've saved some dates for PSP training as TBD. It sounds like I'm not the only one. And then I was realizing, this is next week, and so if we were doing something, we would probably have had an update for you guys. So.
Yeah. No, you're right. And I'm sorry because I definitely don't know what that is, but I will follow up with Jenny and Mallory because it might have had something to do with SGLS originally. But I'll let you guys know. I'm pretty sure that there's nothing next week.
Okay.
Thank you for asking.
Leah, Dr. Hobson, just wondering in terms of the final indicators, when are we going to actually cover those off, Mr. Shafali? The Advanced Care Directive and the Staff Management Goals?
Bruce? Maybe we've lost Bruce.
Sorry, I was on mute. Whatever fits with your schedule. Yep, whatever fits with your schedule. I'm away from October 2nd to the 16th, but happy to start covering them because there are some challenges around dealing with the self-management goals and with the advanced directives, frailty, palliative care that are some of the emails that have been circulated kind of unique to those situations, conditions.
Maybe we can put together some written guidelines around that too and take a little bit of time at our next learning lab to do that before we jump into the EMR functionality stuff.
You know what, that'd be great because I think it just will close the loop around just finishing the work with the physician around the phase 1, right?
Yep, absolutely. All right, we are 9:31, and I'm sure lots of you have meetings. I know I have a meeting, so I will close this off for today. Thanks so much to everybody who shared their experiences and everything, and thank you all for coming. Look forward to chatting with you in 2 weeks, and I'll let you know about next week.
Thanks so much.
Thank you.